Good afternoon. Thank you to Dr. Twinkle Shah for organizing this course, very important course every year, and making me a part of it. So I'll be sharing some of the things that we have learned over the years in power calculation with abnormal corneas. We do receive research grant support from Alcon Laboratories. Now, what are abnormal corneas? I think grossly we can classify them into two types. One is those who have had previous refractive surgery, and the second are those who have some sort of ectatic disease, most commonly keratoconus, but it could also be post-LASIK ectasia or pellucid marginal degeneration, so on and so forth. Challenges that we face in eyes with previous refractive surgery, most important is IOL power calculation, second is the type of IOL, and the third are of course surgical challenges that we face. To understand some of the basics of why they are different is when there is a normal cornea, we all have positive spherical aberrations, which means that the rays at the periphery bend more than the rays at the center. When we do a myopic LASIK, that would mean that we are flattening the central part even further, which means the positive spherical aberrations will actually increase because relative to the center, the periphery will become further more steep. And therefore, if a patient has undergone a myopic LASIK, you would rather have an aspheric IOL, which means an IOL with negative spherical aberrations rather than the one with a spherical IOL with a positive spherical aberrations. Compare that to a hyperopic refractive surgery being done. In hyperopic refractive surgery, we are steepening the center, which means the periphery becomes relatively flatter to the center, which means there's an increase in the negative spherical aberrations. That would typically mean that if a patient has undergone hyperopic LASIK, you should tend to choose a spherical IOL over an aspheric IOL. Post-RK can be anything. It can be good 4-cut RK to zillion-cut RK with corneal scars, and it's very difficult to give one conclusion based on that. Now, why is power calculation in post-refractive surgery as different or challenging is because the ratio of the anterior and posterior corneal curvature is changed. So there is normally a fixed ratio between the curvature of the anterior and the posterior cornea. Whenever a refractive surgery is done, this ratio changes. This either becomes flat or more steep, but the posterior cornea doesn't change. So the ratio symmetrically. So the ratio changes. And therefore, the conventional formulas, which are based on a fixed ratio of the anterior and posterior corneal curvature, do not work very accurately. So we need different special formulas. Now we saw so many instruments, so many techniques, so many technology, and if you go to the trade, I think I'll find 5 or 6 more other newer technologies. Which are the instruments that should be used as far as measurement goes? So I think the consensus definitely is that if you have a good optical biometry, even for measuring the cornea, they are extremely useful and extremely good in giving good power calculations even as far as the corneal measurements go. So I think having an optical biometry definitely gives us an edge in eyes with abnormal corneas and IOL power calculations. I think these are some of the eyes where probably doing a second investigation and looking for the regularity of the cornea can also be important. So for a routine case, non-refractive surgery eye, virgin eye, I think if you find clinically everything is normal, you need not do a topography or a pentacam for IOL power calculation or for toric calculation. But in eyes which have undergone previous corneal surgeries, I think it's important to look at the corneal surface, either just a topography or a Scheimpflug based investigation to look whether the difference in the K1, K2 is actually regular or irregular, because only if it is regular astigmatism can we consider a toric IOL. If it's an irregular astigmatism, irrespective of the magnitude, we should avoid any form of toric IOL. What formula to use, and I think the easiest option is to go to the until for so many years it was the ASCRS website. Now also the ESCRS has its own online calculator for post-refractive surgery eyes. So basically you go onto the website, it's a free formula, and choose what kind of prior refractive surgery has been done, whether it's an RK, hyperopic LASIK or a myopic LASIK. And based on the number of data inputs that you will give with the number of machines that you have, you will get the calculations done by the different formulas that are there. And out of all of that, it will also give you a minimum, maximum, and an average of all the formulas. So it allows you to pick and choose. And if you have any one or two favorite formulas to go to, you can go closer to picking a formula based on the calculation there. So out of these several ones, which all should we use? And unfortunately or fortunately, literature is relatively sort of divided until a very long time. Now most of the studies have shown that the Barrett True K, which is not the Barrett Universal, the Barrett True K, which is designed for post-refractive surgery eyes, seems to be working as well or as bad as most of the other formulas as far as achieving eyes within plus or minus 1 diopter of the targeted refraction. So for a normal myopic or a hyperopic refractive surgery, for at least for us, the Barrett's True K formula is something that we rely on more often than not. We actually did our own study, which we published 3 years back, where we compared the different formulas in patients undergoing corneal refractive surgery, that is LASIK PRK, as well as RK. And what we found was that in the post-LASIK eyes, the minimum when you choose showed the maximum when you out of the ASCRS calculator, the minimum average and the maximum. When we chose the minimum, we had the maximum number of eyes within plus or minus 1 diopter. Whereas in the post-RK eyes, when we chose the average of the ASCRS calculator, we had the maximum number of eyes in the plus or minus 1 diopter. But like I said, RK is still, it's very much on a case-to-case basis that we need to consider. What is the role of measuring the posterior corneal curvature? The discussion that we just had. And there are now machines which allow us to measure the posterior cornea directly, like the Scheimpflug imaging or the Pentacam or the Galili. And there are biometers which actually don't measure the posterior cornea. The IOL 700 also gives you a simulated posterior corneal reading, not the direct capture reading. But yes, you do have now readings of the posterior cornea that are available. So when you go online and go to the Barrett's formula, you have this 2 options. The default is the predicted PCA, which means that the patient, the formula has decided a fixed algorithm based on the anterior corneal curvature that you'll add. But if you want to add your own posterior corneal values, you can just switch the mode to measured PCA and enter the values. As we discussed recently, just before this talk, all of the studies so far have shown that in a virgin normal eye, it doesn't matter whether you use the posterior cornea or not. Very 1 or 2 publications are now starting to come up, which are starting to show that when you use the total keratometry with the IOL 700, there are more chances that you get more patients within plus or minus 0.5 diopter using the total keratometry compared to without using the total keratometry. And in fact, we have been part of a multi-center study which is now in peer review publication, and I can share that actually we found equal number of eyes within plus or minus 1 and equal number of eyes within plus or minus 0.5 diopters with or without the posterior K. The only difference or the only advantage the posterior K gave was that the predicted error was more accurate with the posterior K than without using the posterior K. So it may add a slight edge in special eyes, but it's not a deal breaker measuring the posterior cornea. I think the other challenge is in eyes with post-RK. One is the calculation, but also is second the incisions and the gaping of the incisions. So you may have to do scleral incisions like in this eye with so many cuts. Therefore, your SIA may be very differently. In eyes like this with good gap, you can do incisions between the gaps and you can get away. But in spite of all possible, care taken, very often you may end up with gaping of the wounds, which you may need to suture, and all your astigmatism calculation and IOL power calculation can go haywire. So particularly in post-RK eyes, do tell them that you need to be careful. This is an interesting patient, a patient with a thick vascularized recurrent pterygium, absolutely refuses pterygium surgery. that is not interested in a repeat pterygium surgery, has a significant cataract and as you can see, not a very well dilating pupil. And if you see, there are a lot of irregular aberrations coming from the cornea due to the pterygium. But if we actually zoom in to this dotted zone, which is the actual mesopic pupil capture of the patient, you'll see that there is a regular bow tie appearance in this pupillary zone that the patient has. So although the patient has significant pterygium, we did counsel him for a toric IOL, and the patient did very well post-operatively with a very minimal residual error left behind. Keratoconus, coming to keratoconus or ectatic disorders. Keratoconus is a term I'm broadly using for ectatic disorders. Unfortunately, there is no consensus. And the reason is, it's a very variable disease. It depends on the severity of the keratoconus, the location of the cone, and therefore literature is limited. We don't know, there's a lot of debate on what keratometry to rely on. Should we rely on a more central keratometry? Should we rely on the mid-peripheral keratometry? What is the true actual anterior chamber depth because of the corneal thinning, and therefore the effective lens position? And most of the formulas I've shown to give hyperopic outcomes as far as keratoconus goes. So there are now number of publications coming up. I'm just sharing one of them, which is a review which compares the different IOL power calculation formulas in keratoconus. And unfortunately, all of them give different answers. And most of them have shown, the review in the end concludes that most of the studies have shown that in keratoconus, the SRK-T yielded the best outcomes, even better than the third generation and the Barrett Universal 2. And that's probably because it uses the least number of parameters for IOL power calculation. Of course, there are newer formulas which are under peer review, but unfortunately, because it's not such a common disease, we still really don't have a go-to formula as far as keratoconus goes. But I think the newer formulas like the cane and the keratoconus mode in the Barrett's Universal 2 should help us to improve it in these cases. I'll just share one case of a known case of keratoconus diagnosed after her first pregnancy. Presented to us with cataract and never used contact lenses, was managing with glasses with high astigmatism. And when we looked at her pentacam, there is, as you can see in her mesopic pupil, there is reasonable regularity of the astigmatism. The right eye is relatively better compared to the left eye. And you can see more than 5 diopters of astigmatism measured in both eyes. When we did the IOL power calculations, one using the Barrett's keratoconus mode, it showed even with the maximum powers that we had to use, we will be left behind with about 2 or 3 diopters of astigmatism. And again, if you notice here, KC mode, which means the keratoconus mode in the Barrett's 2K formula, suggested somewhere between 11.5, 12, 12.5 and 14.5 to 15.5 in the left eye. So we counseled the patient 2-3 times that we don't know what the refraction would be post-operatively, and we went ahead with a 12 diopter T9 first myopic target and 14.5 in the other eye, the first myopic target. And fortunately, we were reasonably on target. The patient ended up with a +1 in the right eye with a -2 cylinder and only with astigmatism in the left eye. And she's extremely happy and she's accepting glasses is quite well. So I think, to summarize, there are multiple challenges in abnormal corneas, calculating, measuring what kind of IOL. Post-LASIK and post-PRK calculations have now become quite predictable and reliable, almost as good as our normal eyes. But I think post-RKs and keratoconus or ectatic disorders continue to remain a challenge. Thank you so much for the patient listening.